Okay.
Good evening, Vani. Good
Good
evening, Dr. Vani.
Good evening.
Good evening, Dr. Vani.
Good evening.
Wally, wait for a while.
Maybe is it clear now?
Yeah, better than before.
Yes.
Thank you. Because when you will be showing the location, then it will be easier.
Okay. One thing, treatment part will be taken by Rahul sir. This is the anatomy revision class.
Okay. Thank you.
Okay. Okay.
Good evening, ma'am.
Good evening, sir.
Good evening, ma'am.
Good evening. One second.
Can you see the screen?
Yes, yes. One second.
So this is a tutorial on the muscles of the gluteal region.
Hi, Mama.
Yes. Shall we start now? And I want
Yes.
the image to be shared first. Image.
Image?
Pelvis
Oh,
image.
okay, okay.
Yes.
Just a moment, yeah. Yeah.
Yes.
Can see, right? Yeah.
Yes. The class is going to be a revision for muscle anatomy of the muscles of hip and thigh region, because we know Shastri sir's technique is it's very nice and very effective too. And as we say that even I feel his pen is like a magic wand. When we use a magic wand, we have to cast a spell, and like this, to use this pen, we need to be very thorough with the location of these muscles. That's what we are going to discuss today. Okay. For this, first, let us see some important landmarks of this pelvis. First is this. Can people see my cursor moving?
Yes, yes, we can see.
Okay, okay, thank you. So, first in the pelvis, we have three bones that combine to form this pelvic bone. One is the ilium, and one is ischium, another one is pubis. These three combine to form this pelvic bone. Okay. And this pelvic girdle is formed by two pelvic bones and this sacrum. And the important landmarks of this pelvis would be the anterior superior iliac spine, because most of the muscles that gets connected to this, and this posterior superior iliac spine, and this is ischium tuberosity, and pubic superior ramus and inferior ramus. If I am going speed, kindly just let me know so that I can go slowly. Is it okay for people to understand the accent?
Yes, ma'am.
Okay.
Just a bit slower.
Sure,
Thank
sure,
you.
sure. That's what. So now these important things, because the ischium tuberosity, this ischium tuberosity, and the inferior ramus, superior ramus, and this anterior superior iliac spines, these are all going to be repeated for the muscle attachments. So these things please remember, and when we go to the video also, we can get a clear picture of that. Okay, please share the first part video.
Okay, so this is a tutorial on the muscles of the gluteal region and the muscles of the thigh.
Can I
So
have
I'm
a
gonna
control over it?
cover quite a lot of muscles here, but I'm not going to.
Can I have a control over it?
Yeah, you need to. We need to share this thing.
Okay, okay.
Let me see. I'm not sure whether how to. Okay, I think you need to share this. Or you want me to control it, or then you just say stop, I stop.
Okay, sure, sure, sure.
Okay.
Because surely one day I will get the class from
Yeah, no
regarding this.
Yeah.
Okay.
And to go into
this
huge
is-
amount of detail because I've done that in some other
First,
individual
please
tutorials.
pause it. Please pause it.
So the gluteal region is this region here between
Please pause. Okay. Now we are going to see about the muscles of the pelvis region and the thigh. In pelvis, we will be seeing the gluteal region, back muscles, and in thigh is divided into three compartments. One is the anterior compartment, and medial compartment, and posterior compartment. These muscles we are going to see individually. One is because even when I am treating patients, I feel that because when I started with Sir's pen for the treatment, I was thinking for knee pain, okay, let us use the pen on the knee joint corresponding area on the brain mapping. That worked for some people, but they did not feel much relief. Then I realized some muscles need to be concentrated well. So then, okay, let us concentrate only on quadriceps and hamstrings because those two are very important for the knee joint. I thought like that and I was working. Even then, some people they got relief and after it got relapsed. Then I realized other muscles should also be worked. So then, hip muscles also should be treated, and abdominal muscles also should be treated. Now, then at that time only, I came to know the importance of using all the muscles in this knee joint pain treatment as per the NABS. Is the speed is okay? I am going speed. Should I go slow?
Go slow.
Oh, sure, 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 sure.
Thank
So,
you.
yes. We need to work on many muscles. We can't say for the knee joint for one person we might have to choose the gluteal muscle. For another person we have to work on the abductors of the hip also. For one person we might work on the adductors also. It differs by the pattern of the pain that they are experiencing, and it is an example I'm saying for the pattern of the pain they are experiencing, and also the muscle that is weakened for them, that also we have to check. Unless we find the weakened muscle or the muscle that is not producing any particular action, or the muscle which is supporting the weaker muscle, if we don't find these, we cannot get the results of NABS. Okay. Now, here first we will see the gluteal region muscles. Initially, it will be the superficial layer. In gluteal region, the muscles are arranged in superficial layer and the deeper layer. In superficial, first we will be seeing about gluteus maximus, and next is gluteus medius, gluteus minimus, and then followed by the deeper layer that consists of piriformis and the rotators of the hip. Is it clear? Is it clear?
Yes, ma'am.
Yes, Dr.
Yes,
Vani.
it's.
Yes, ma'am.
Okay, okay.
Yes, doctor.
First, let us see about the gluteus maximus, which is a very large muscle of this and which is very important in treating the most of the conditions. When we treat the stroke patients also, it is very important, because one day I treat them with gluteus maximus. When we increase the power of gluteus maximus, the next day we feel that I felt that the power is lowered. It is not lowered, but from that gluteus maximus, the power which was given by the pen has been transferred to
rosemary, sage, tea tree, thyme, and wintergreen. So these oils are extracted from leaf.
the power which was given during the treatment has been transferred to the other muscles. So which is really very nice to see the results also. When we treat the patients, the gluteus maximus which we treat, the next day the patient will feel improvement, but we cannot see that much of what we have initial day. The one day when we treat the gluteus maximus, the power goes to 3, but next day it will become 2, but they will feel the strength, but the power of gluteus maximus would have been transferred to other muscle. So we should repeatedly treat the gluteus maximus in the stroke cases. First, this gluteus maximus, we will watch this. Please play the video.
That in some other individual tutorials. So the gluteal region is this region here between the iliac crest and the gluteal fold, so the folds of the buttock. So it's helpful to think of the gluteal region in terms of deep and superficial muscles. So the deep muscles are small little muscles and are mainly lateral rotators of the hip. And then you've got the large powerful superficial group, which you can see here, which are mainly extensors and abductors, abductors of the hip, the femur at the hip. So you've got 3 muscles in the superficial region. You've got this muscle here, which is the gluteus maximus, and this muscle is innervated by the inferior gluteal nerve. Next, you've got the gluteus medius, which lies just underneath. So you can see this fan-shaped muscle here, and this abducts the femur. And you've got the minimus, which lies underneath, and that is also an abductor, so it works together with the gluteus iliac crest and the gluteus.
Okay. First, we were seeing layer by layer. First, we saw that gluteus maximus, and second is the gluteus medius, and third is the gluteus minimus. Like that, layer by layer, we have to understand the muscle's position. Yes, please play that.
Sorry, I accidentally pressed something just now and I don't know where's the pointer, but we start from here, okay?
Okay.
And superficial muscles. So the deep muscles are small little muscles and are mainly lateral rotators of the hip. And then you've got the large powerful superficial group, which you can see here, which are mainly extensors and abductors, abductors of the hip, the femur at the hip. So you've got 3 muscles in the superficial region. You've got this muscle here, which is the gluteus maximus, and this muscle is innervated by the inferior gluteal nerve. Next, you've got the gluteus medius, which lies just underneath. So you can see this fan-shaped muscle here, and this abducts the femur. And you've got the minimus, which lies underneath, and that is also an abductor, so it works together with the gluteus medius. So those are the 3 gluteus muscles: gluteus maximus, medius, and minimus. And then you've got this muscle here, the tensor fasciae latae muscle. So this muscle inserts onto this band of fascia, the iliotibial tract, and what this muscle does is it stabilizes the knee in extension. So that's the tensor fasciae latae muscle.
Yes, please pause it. Yes. This tensor fascia lata is one of the gluteal muscle which helps in controlling the knee movement. Okay. We will see next, please. We will go to the deeper layers next.
So those are the four muscles of the superficial group in the gluteal region. And next you've got these, you can see these muscles underneath, which are the muscles of the deep layer. And these are mainly lateral rotators of the femur.
Please pause it. Now we will be seeing about the piriformis and gemellus superior, gemellus inferior, obturator internus, obturator externus, and quadratus femoris. Please play.
Dr. Vani, sorry.
Yes.
Do you have one that with the label?
What's up?
With the when you mentioned the piriformis muscle, is there one that indicate
Yes,
the other
sir.
muscle as well?
Yes, sir. If in this video itself we can go muscle by muscle, individual
Yeah,
muscle.
I mean, is there any indication?
Yes. Yeah, it is. You are asking me?
Yeah.
Pardon, sir. Please repeat your question again.
No, I mean, here it's shown the muscle, but you know, if we can have the wording to indicate, is even better. Label the muscle.
Okay.
Yeah.
This is the piriformis.
Yeah. So which one?
This one. My cursor. You're not able to see the cursor.
Dr. Vani, you want
Yes.
to try click the annotate. And once you click the annotate, you come out with a lot of small little icons. There's a first one that says mouse.
1 second.
Yeah, you try that. Yeah.
Yes.
Annotate.
Okay.
Do you see some icon? Yeah. No, not please, nobody else, but except Dr. Vani.
Okay. So mouse, yes.
Yes, okay, you can try your mouse.
Can you see now?
Cannot see your mouse.
Oh my God.
Never mind.
Even I clicked it.
Or you can put your mouse there and then type the text for Rodney if you want.
Is it clear to you? No? Is it clear to
Who?
Is it clear to the people that mouse is moving? The cursor is moving?
The mouse is not
Vani,
moving.
you can type the
I didn't
words
see the
is
cursor
better.
moving.
Indicate with the words the various muscle.
Yes.
He wants
That
you
is
to
possible.
insert the text with the name of the muscles there.
Yes. You want me to text the name of the muscle?
Yes.
Okay. Now we'll see about piriformis. Please play the video.
I'm going to talk you through these muscles from superior to inferior. The top muscle here is the piriformis muscle, and this muscle originates on the sacrum. So if I just fade away the other muscles, you can see where it
That's very good.
originates. So you
Okay.
can see it.
Thank you.
It's on this anterolateral surface of the sacrum, and it inserts onto the femur, so it laterally rotates the femur. So an important thing I want to point out is the greater sciatic foramen. So if you look at this side, you've got the greater sciatic notch in the pelvis, and you've got this little bump here, which is the ischial spine of the pelvic bone. So you've got a ligament which runs from the ischial spine to the sacrum, and that's called the sacrospinous ligament. So above the sacrospinous ligament, you've got the greater sciatic foramen, and you've also got another ligament which lies posteriorly to the sacrospinous ligament, called the sacrotuberous ligament, which is oriented more vertically. So the greater sciatic foramen is this space between the greater sciatic notch and the sacrospinous and sacrotuberous ligaments.
Yes.
So you can
Please
see that.
pause it.
I lost
I'll just
control.
rotate the model over and show
You lost control.
Yep. Just a
So
moment.
this is the tuberous ligament, sorry, the sacrospinous ligament running horizontally from the ischial spine to the sacrum, and you've got the sacrotuberous ligament which runs vertically from the ischial tuberosity to the sacrum. So that's why it's called the sacrotuberous, so referring to the ischial tuberosity, sacrotuberous.
Can you pause it?
So the reason I mentioned this is that the piriformis runs through this greater sciatic foramen, and there's two little gaps above and below the piriformis.
Yes.
So above the piriformis, you've got some vessels and nerves that pass through, and below the piriformis, you've got
I
vessels
think
and nerves that
I
pass
lost.
through. So importantly, below the piriformis, you get the sciatic nerve, and above you get the superior gluteal nerve and vessels. So you can see the sciatic nerve emerging below the piriformis in the greater sciatic foramen. So it's above the sacro.
What can we do now? Okay. Now it's paused. Hello?
Oh, where shall we stop? I lost control for a while.
Oh,
Yeah? Yeah, can.
yes.
So above the sacrospinous ligament, you've got the greater sciatic foramen, and you've also got another ligament which lies posteriorly to the
Please pause it.
sacrospinous.
Pause it. Pause it. Okay. Here, one thing we should remember, that sciatic nerve passes below this piriformis muscle. That we have to remember. In some people, it passes above also, but mostly it passes below this piriformis muscle in this greater sciatic notch. This is called as greater sciatic notch. In this, piriformis muscle is over here, and the nerve passes below this piriformis muscle.
Hello. Hello.
Is it clear?
ಹೇಳಿ
Is it clear?
ಹೌದಾ
Yes, madam.
Yes, ma'am. Yes, ma'am.
Okay.
Yes.
Please, yes, please play the video.
Ligament called the sacrotuberous ligament, which is oriented more vertically. So the greater sciatic foramen is this space between the greater sciatic notch and the sacrospinous and sacrotuberous ligaments. So you can see that here. So I'll just rotate the model over and show a bit more clearly here. So this is the sacrotuberous ligament, sorry, the sacrospinous ligament running horizontally from the ischial spine to the sacrum, and you've got the sacrotuberous ligament which runs vertically from the ischial tuberosity to the sacrum. So that's why it's called the sacrotuberous, so referring to the ischial tuberosity, sacrotuberous. So the reason I mentioned this is that the piriformis runs through this greater sciatic foramen, and there's two little gaps above and below the piriformis. So above the piriformis, you've got some vessels and nerves that pass through, and below the piriformis, you've got vessels and nerves that pass through. So importantly, below the piriformis, you get the sciatic nerve, and above, you get the superior gluteal nerve and vessels. So you can see the sciatic nerve emerging below the piriformis in the greater sciatic foramen. So it's above the sacrospinous ligament, but below the piriformis. And you've got the superior gluteal nerve coming above the piriformis. So just below the piriformis muscle, you've got this muscle called the superior gemellus muscle, or the gemellus superior. And you've got the gemellus inferior below here. But in between, you've got this muscle called the obturator internus muscle. So the obturator internus muscle actually sits, just get rid of these muscles, ligament. So this is the obturator internus muscle, which sits on the medial surface of the obturator membrane. So I've just isolated this muscle so we can take a look at it. So this is the obturator foramen.
This is the obturator foramen. From here, the muscle goes like this. Can you see the cursor? Can you see the cursor? No.
No, we can't. No, we can't see it.
Yes.
Now? Now?
Yes, there is
Yes.
a cursor, but
Okay.
it is not moving.
Oh, that is the cursor in the video. Okay, you're not able to see my cursor.
No.
Okay, so please play the video.
And you've got a membrane which covers it. On the lateral surface, on the external surface, you've got a muscle called the obturator externus, which I'll talk about shortly. But this muscle is the obturator internus because it lies on the medial surface or the internal surface. So you can see it originating here, and it bends 90 degrees round and then comes to insert on the femur at the greater trochanter. So that's the obturator internus muscle. You can see that 90-degree bend and its origin on the obturator membrane on the medial surface. So you've got the piriformis, then you've got the superior gemellus, the gemellus superior, the obturator internus, and then the gemellus inferior underneath the obturator internus. So just inferior to the gemellus inferior, you've got this quadrangular shaped muscle. So this is called the quadratus femoris muscle, and this again externally laterally rotates the femur. All these muscles laterally rotate the femur, but
Please pause it.
these four muscles.
Please pause it. Yes, we are seeing the external rotators of the hip joint. First is the piriformis muscle, where the cursor of the video is there. And next to it is the superior gemelli, and next to it is the obturator internus below that, and below obturator internus is the inferior gemelli, and this quadratus femoris. All these muscles works as the external rotators of the hip joint. These muscles works as the external rotators of the hip joint. Please.
Muscles actually can extend the hip at the extend the femur at the hip joint, as well as laterally rotating, but the quadratus femoris only laterally rotates. So the piriformis and this gemellus superior muscle are innervated by the gemellus superior and the obturator internus muscle are innervated by the nerve to the obturator internus, and then the quadratus femoris and the inferior gemellus are innervated by the nerve to the quadratus femoris. The piriformis is innervated by branches from S1 and S2. So those are the muscles of the gluteal region. So just remember they're split into deep and superficial layers. So next I'm going to talk about the muscles of the thigh region. So the thigh can be split into three compartments. You've got an anterior compartment, a posterior compartment, and a medial compartment.
Please pause the video.
Separated by
Yes, in anterior compartment of the thigh, we are going to see about iliopsoas, that is iliacus and psoas major. Both has got different origin, but they both get insert at the lesser trochanter. And another muscle is sartorius. These muscles we see in the anterior compartment of the thigh. We always say that many issues, even last week also Rahul sir discussed regarding the piriformis syndrome and the emotions. In that also he was explaining about psoas major as iliopsoas as the muscle of the soul, because it is since the child, once the child reaches at 4 or 5 years, we put them into the school and their schooling starts, and they are trained in sitting for longer duration. In this sitting for longer duration, hip goes for flexion. This muscle is always stressed. It is always in a contracted position. This goes for most of the time the tightness of this iliopsoas takes place. Okay, let us see about the muscle.
by intermuscular septa. So the anterior compartment is mainly innervated by the femoral nerve. The medial is only innervated by the femoral nerve. The medial compartment is mainly innervated by the obturator nerve, and the posterior compartment, the hamstrings, are innervated by the sciatic nerve, or branches of the sciatic nerve. So the anterior compartment consists of the quadriceps muscle, which consists itself of 4 different muscles, as the name suggests, the sartorius, and then the terminal ends of the iliopsoas muscle. So let's just take a look at the iliopsoas muscle. So the iliopsoas muscle makes up part of the posterior abdominal wall, so I'll just remove the muscles and we can take a look at them. So you can see that it consists of 2 muscles. You've got the psoas major and the iliacus. So the iliacus muscle, you can see it sitting here in the iliac fossa, and you can see the psoas major originating on the vertebral bodies here, and then it winds down to form this common insertion point on the femur. So this muscle has 2 origins. You've got the psoas major originating up here, and you've got the iliacus muscle originating in the iliac fossa. And these muscles collectively are known as the iliopsoas muscle. So what this does is it flexes the femur at the hip joint. So as you can see, the terminal ends of this muscle are part of the anterior compartment of the thigh. So this psoas major muscle is innervated by the anterior rami of L1, 2 and 3, and the iliacus muscle is innervated by the femoral nerve, along with the other muscles of the anterior compartment. So just take a look at the rest of the muscles. So we'll start off with this muscle here. This is the rectus femoris muscle. So the quadriceps muscle consists of 4 muscles, as the name suggests. You've got the rectus femoris, and then you've got the 3 vastus muscles. So you've got the vastus medialis, which is this teardrop-shaped muscle on the medial side. You've got the vastus lateralis, which is this muscle sitting laterally. And you've got the vastus intermedius, which lies underneath this muscle here, the rectus femoris muscle. So these 4 muscles converge at this common insertion point onto the patella bone via the quadriceps tendon, and then the patella attaches to the tibial tuberosity via the patella ligament. So the rectus femoris muscle is interesting because it attaches to the pelvic bone, so it acts also as a hip flexor, whereas the vastus muscles originate on the femur, so they only extend the knee. So if we just take a look at these muscles in isolation, so you can see this muscle, the rectus femoris, it inserts onto the originates on the anterior inferior iliac spine, and there's also another head which isn't shown here, which is reflected back, inserting superiorly to the acetabular fossa. So it originates on the pelvic bone, which allows it to act as a hip flexor. So removing the rectus femoris, looking underneath, you can see this muscle here, the vastus intermedius. So this lies between the vastus lateralis and the vastus medialis. So you can see these muscles have an origin on the femur, and they insert onto the patella tendon via this common quadriceps tendon. Sorry, they insert onto the patella via this common quadriceps tendon. So they act to extend the leg at the knee joint. So the quadriceps are innervated by the femoral nerve. So next we've got this muscle, which is the last muscle of the anterior compartment. It's called the sartorius, and it also originates on the pelvis, and it winds round, descending along the thigh obliquely to insert on the medial surface of the proximal tibia. So that's the sartorius muscle. So I've just isolated it again, and you can see its origin here on the anterior superior iliac spine, and it winds down like this, like a band, onto the medial surface of the proximal tibia. And this again is innervated by the femoral nerve because it's in the anterior compartment of the thigh. So because this muscle originates on the pelvis, it also acts as a hip flexor, and it also flexes the leg at the knee joint. So unlike the quadriceps, which extend, this flexes the leg at the knee joint and also flexes the hip joint.
And so one day, Jill said to me that you have messed.
So now we're going to move on to the medial compartment of the leg. So the medial compartment
Please pause
consists
it.
of 6 different muscles. So
Yes. In medial compartment, we will be going to the adductor muscles, adductor magnus, adductor longus, adductor brevis, pectineus, and gracilis. All these muscles we will be seeing, and in this, this medial compartment is supplied by the obturator nerve. And most of the people, they get this adductor tightness, which is the main reason for back pain as well as the neck pain also. This adductor gets tightened frequently, and these adductor muscles goes for tightness frequently, and we have to check these muscles while treating the knee pain. And for um, stroke people, hemiplegia, we have to work work to release the tightness of this adductors, because of this tightness, which causes very severe, even I have witnessed one patient, he complained of severe back pain. But when I was treating his spinal muscles, he was getting relief, but not up to the 100%. He was getting only 50-60% for even after some 7-8 sittings. Then I checked his adductors, which was very tight, and then I worked it according to the NABS, and he got complete relief from the back pain. Yes, please.
we'll take a look at those now. So I'll just get rid of the sartorius, and we can look at the medial compartment muscles. So these muscles originate in this area of the pelvis. So sort of the body of the pubis, the ischiopubic ramus, this sort of area is where the muscles of the medial compartment originate. And these muscles are mainly innervated by the obturator nerve. So there's 2 muscles that are innervated by separate nerves. You've got the pectineus muscle, which is this muscle here, and that's innervated by the femoral nerve. And you've got the hamstring part of the adductor longus muscle, which is innervated by the sciatic nerve, so by the tibial branch of the sciatic nerve. But apart from that, they're all innervated by the obturator nerve. So these muscles, these group of muscles, mainly adduct the femur at the hip joint. So the first muscle I'll talk about is this muscle, which is most medial, and it runs vertically down the medial aspect of the thigh. So this muscle is called the gracilis muscle. So you can see its course down the inside of the leg from the body of the pubis, inserting onto the medial surface of the proximal tibia. So it inserts just behind the insertion point of the sartorius. So this muscle adducts the thigh and it flexes the knee. So next we've got the pectineus muscle. So you can see this muscle here is a sort of rectangular in shape, and it's innervated by the femoral nerve rather than the obturator nerve. So I've just isolated it here, and you can see it originating here on the pectineal line and inserting onto the femur. So what this muscle does, it adducts and flexes the thigh at the hip joint. So that's the pectineus muscle. And then we've got a group of muscles called the adductor muscles. So you've got the adductor longus, the adductor brevis and the adductor magnus. This is the most superficial of the adductor muscles, and this is called the adductor longus. So this muscle adducts and medially rotates the thigh, and the medial border of this muscle forms the medial border of the femoral triangle. So I've just brought back the sartorius muscle. So the femoral, just to explain the femoral triangle. So the femoral triangle is this area in the upper thigh. So the superior border is the inguinal ligament, which runs from the anterior superior iliac spine down to the pubic tubercle. So that's the superior border. Then you've got the lateral border formed by the medial border of the sartorius muscle. So this margin here. And then, like I just mentioned, you've got the medial border of the adductor longus muscle, which forms the medial border of the femoral triangle. So the femoral triangle is this region here. So the adductor longus and the pectineus muscle adjacent to it form the medial part of the floor of the femoral triangle. And then you've got the lateral part formed by the terminal ends of the iliopsoas muscle. So that's just a quick bit about the femoral triangle. So I'm just going to dissect away some of these muscles. So you've got the pectineus here, you've got the adductor longus, which I've just shown you, and I'm just going to remove that muscle so we can see what's beneath. So you've got this smaller muscle which inserts on the femur a little higher up in the upper third of the femur. So this is called the adductor brevis. So remember, brevis means short in Latin, so it's a shorter muscle. The adductor longus inserts further down here. So this muscle, the adductor brevis muscle, lies behind the pectineus and the adductor longus muscle, and this muscle adducts the thigh. So most deep, we've got this huge muscle underneath, so I'll just get rid of the adductor brevis, and we can see this big muscle here, and this is called the adductor magnus muscle. So magnus means big or great in Latin, so it's the biggest adductor muscle, and it's got two parts. It's got a hamstring part, which is this part here, which sort of runs up vertically, and you've got the adductor part, which is this part here. So I've just isolated it to give you a good view. So you've got the hamstring part, which sort of runs vertically up, and you've got the adductor part, which is this part here. So the hamstring part of the adductor magnus is innervated by the tibial branch of the femoral nerve rather than the obturator nerve. So this part, the adductor part, is actually innervated by the obturator nerve, and they've got two different origins. So the hamstring part essentially descends vertically and it originates on the ischial tuberosity, whereas the adductor part originates on the ischiopubic ramus. So this muscle adducts and medially rotates the thigh. So finally, we've got the obturator externus muscle. So you can see this muscle here. So it sits on the lateral surface of the obturator membrane, and it winds round behind the hip joint to insert into an oval depression in the trochanteric fossa. So just isolate it again here. You can see it sitting on the obturator membrane over the obturator foramen, and it winds round behind the hip joint and it inserts into this little depression here, the trochanteric fossa. So this muscle externally rotates the thigh. So if you remember the obturator internus muscle, it sits on the medial surface of the obturator membrane. So you can see that there, and it's 90-degree bend round. So you can see the obturator externus and internus. So again, the obturator externus is innervated by the obturator nerve. So just bringing back the muscles of the medial compartment, you've got two muscles which aren't innervated by the obturator nerve in the medial compartment. You've got the pectineus muscle, which is this rectangular muscle here, innervated by the femoral nerve, and you've got the hamstring part of the adductor longus muscle, which is innervated by the tibial branch of the sciatic nerve. But apart from that, the rest are innervated by the obturator nerve. Okay, so the final compartment of the thigh is the posterior compartment.
Please pause it.
So the posterior compartment is very simple because you've only got 3 muscles there.
Yes. In posterior compartment, the hamstring muscles are there. They are biceps femoris, semitendinosus, and semimembranosus. And these muscles help in the extension of the hip as well as flexion of the knee. In case of circumdactory gait, as we can witness in paralyzed patients, they experience this circumdactory gait because of the weakness of this hamstring, where the person cannot make knee flexion, which in that to compensate that, they just make the circumdactory gait. And this is very important because most of the people get tightness of this hamstrings, which results in the back pain, and which also shift the which also changes the tilt of the pelvis. Okay, let us see about the hamstring muscles.
So I'll just remove the gluteus maximus to get a good look at this compartment. So the muscles in this compartment are innervated by branches of the sciatic nerve, and these muscles, apart from the short head of the biceps femoris muscle, these all originate on the ischial tuberosity, and they run down to insert on the tibia, and they extend the hip joint and flex at the knee joint. So you've got 3 muscles. You've got this muscle here which sits laterally. This is the biceps femoris muscle, and it has 2 heads. You've got a long head which originates on the ischial tuberosity, and you've got a short head which originates on the femur, and it inserts onto the head of the fibula. And then medially you've got the semimembranosus muscle and the semitendinosus muscle. So a way of remembering it is semimembranosus has an M in it, so M medial, and semimembranosus and semitendinosus both have a semi in it, so that they both go together, so they're both medial because semimembranosus is medial, so semitendinosus is medial. And then semitendinosus has a T in it, so semitendinosus sits on top. So biceps femoris laterally, and then you've got semimembranosus and semitendinosus medially, with semitendinosus sitting on the top. So I've just isolated these muscles, and you can see the origin of these muscles on the ischial tuberosity, and then you can see the short head of the biceps femoris muscle originating on the femur. So the long head and the short head converge into this common tendon and then insert onto the head of the fibula. So the biceps femoris muscle extends at the hip joint and flexes at the knee joint. So the semitendinosus is the one that sits on the top, and it's medial to the biceps femoris muscle, and it runs down and inserts on the medial surface of the proximal tibia. So it inserts just behind the gracilis muscle. So if I just bring the other muscles back in, you can see the gracilis here running down, and it inserts just behind the sartorius muscle, but just in front of the point where the semitendinosus muscle inserts. So the semitendinosus muscle, again, it flexes the knee and it extends at the hip. So the semimembranosus muscle has the same action, extending at the hip and flexing at the knee joint. So it works together with the semitendinosus muscle. But let's just have a look at the insertion point. So it actually inserts behind on the medial condyle of the femur, and it also inserts posteriorly on the medial condyle of the tibia. And it also, some of the fibers from the tendon blend with the fascia which covers the knee joint. So all these muscles of the posterior compartment, well, the three muscles of the posterior compartment, are innervated by the sciatic nerve. So the main function of these muscles is to extend at the hip, flex at the knee. So that's the muscles of the gluteal region and of the thigh. It's probably quite long, but if you want to learn a bit more in detail about the various muscle actions and
Please
the
pause it. Please
points
pause
of
it.
origin and insertion, then take a look at my individual.
I have shared you one PPT. Sorry, one PDF. Please share it. Vidi ma'am, I have shared you one PDF. Please share it regarding the muscles.
It's downloading. Because I cannot go to your chat at the same time. I want to control the slide. Okay, no problem.
Okay.
Okay. So you can explain now.
Yes, that's
Wow.
what.
Okay.
Please share the PDF.
Can you all see?
Yes.
Yes.
Yes. So individually we can see the muscles now. It's a quick review, we will make it. And then we can go for the questions. Now the gluteus maximus, which is the superficial muscle of the back region, it originates from the posterior, it originates from the iliac crest and the sacrum also. Can you see my cursor? No? No?
No. No, ma'am.
You are already the co-host and you have the annotate rights. I cannot see. You want to share the PDF yourself, then you can control.
Yes, I just want to control it.
Yeah. So you want to share a screen?
Yes.
Okay, so you go to are you sharing from your PC?
Yes.
Okay, so you open this PDF file, and then you see a share screen. So you click the share screen, then you will come up with many small little window. So you look for the PDF file that the screen that shows the PDF file, and then you share that particular one. Then it will come up.
1 second. It's in the WhatsApp actually. It's not in the.
Oh, it's okay as well. You click. Let me see. You go to your share screen, and you should look for the WhatsApp screen. Once you go to the WhatsApp, you just click the WhatsApp. I will click the PDF inside the WhatsApp, and it should open. Else, you save the file into your local drive, then you open the file from the local drive, and then you share the screen of the local drive.
1 second. I need to go to the WhatsApp screen, right?
Yeah, if you are sharing from the WhatsApp.
Okay.
Best is that you download into your hard drive, and you share.
Okay, please you control it. That would be much better.
Okay.
Okay. You just put the cursor over the muscle, gluteus muscle. Yes. So this gluteus maximus is the hip extensor and the external rotator of the hip, and it is also the another other gluteal muscles like gluteus medius, gluteus minimus are all like abductors of the hip. Please next slide. Next slide. Gluteus medius also arises from the ilium, because I just want to give a very simple view of the muscles so that it comes into your mind and easily we can go to the NABS also. That's why I'm just giving a simple view of this. I'm not mentioning it is from the very deeper structure, like if this is from this also from the sacrus posterior part, all these things. But I'm just showing this picture of to remember the muscle so that we can imagine this picture of these muscles on the finger also, and then we can work on the NABS. Gluteus medius, it helps in the abduction of the hip and the internal rotation of the internal rotation and the external rotation of the hip. Next. Gluteus minimus, it is the deepest when compared to the first layer is gluteus maximus, next is the gluteus medius, and the third one is the gluteus minimus, which helps in the abduction as well as the internal rotation and flexion of the hip. Next slide, please. So this one is the first layer is gluteus maximus, and the second is the gluteus medius, and the innermost is the gluteus minimus. Next slide. You can see gluteus maximus, medius, and then the minimus. Next slide. Now we are seeing the posterior thigh muscles. Those are hamstrings. This biceps femoris and semitendinosus and semimembranosus. These three together form the hamstring groups. Next. Biceps femoris. It has got two heads. One arises from the ischial tuberosity, and short head arises from the lower half of the linea aspera of femur, and it inserts into the head of the fibula. It inserts into the head of the fibula. It helps in the extension of the hip and the external rotation of the hip. Next. Semitendinosus. Semitendinosus, it arises from it's in ischial tuberosity, and it gets inserted into the proximal end of the tibia. Please. Can you show the proximal end of the tibia in the cursor? Yes. Yes. It arises from the ischial tuberosity, and it gets inserts into the proximal end of the tibia. It helps in the extension of the hip, internal rotation of the hip, and it also helps in the flexion of the knee. Next. Now comes the semimembranosus, which is deeper than the semitendinosus, and it is also the biceps femoris will be in the lateral in hamstrings. When we compare from lateral to medial, biceps femoris in the lateral, and semitendinosus, and then comes the semimembranosus. From lateral to the medial direction, first comes the biceps femoris, which inserts into the fibula, and next comes to the semitendinosus, and next to that is semimembranosus, which also gets inserted to the medial surface of the tibia. These muscles helps in the extension of the hip, internal rotation of the hip, as well as the flexion of the knee. Next slide, please. Yes, you can see The biceps femoris. Biceps femoris, please. This side. Yes. This one is biceps femoris. Next one is semitendinosus, and this one is semimembranosus. Next slide, please. Tensor fascia lata. It is it arises. It's a small muscle which is also the part of the gluteal muscles. It arises from the iliac crest and it gets attaches to the iliotibial band, which is a thick connective tissue, and this helps in the flexion of the hip, internal rotation, as well as the abduction of the hip. Next slide. Anybody finds in difficulty to understand the flexion, extension, and abduction of the hip? Anyone? Anyone finds it difficult to understand flexion, extension, abduction of the hip? Is it?
Can you just go through it quickly, please?
Yes.
Thank you. Just a review, please. Thank you.
Next is the tensor fascia lata. Tensor fascia lata, it is also the part of the gluteal muscle and which gets inserted into the IT band. Next, iliopsoas. Yes, iliopsoas, the two muscles originate from the two different places. Please show the psoas major muscle. Yes, psoas major, which originates from the lumbar vertebra, and iliacus muscle. Please show the iliacus muscle, which gets originate from the iliac fossa. Both combinedly get inserted into the lesser trochanter of the femur, and this muscle is like most of the people have tightness of this iliopsoas, and it helps in the flexion of the hip. Next. And next is the pectineus. Please show the pectineus muscle. Yes, the small muscle which arises from the superior ramus of the pubis, and then it gets inserted into the linea aspera. Its action is flexion, adduction, and external rotation. Next. Tensor fascia lata, this one, and pectineus, the adductor muscle. Okay. Next slide. It is adductor brevis. Please show the adductor brevis. Yes. Adductor brevis, it originates from the inferior ramus of the pubis. Inferior ramus of the pubis, and it gets inserted into the pectineal line of the femur. Its action is adduction, external rotation, and it is a weak flexor. Next. So these are adductor groups. Pectineus, please show the pectineus. Please show the pectineus in the second one. Pectineus, above. It's in the second picture. Yes. Pectineus, and below it is the adductor brevis, and this thinner muscle is the gracilis. Next slide, please. Adductor longus, it arises below the adductor brevis, and it arises from the superior ramus of the pubis, and it gets inserted into the linea aspera. Its action is adduction as well as a weak flexor. Next. Adductor magnus, it is located posterior to the longus, because when we go from the anterior to the posterior direction of the adductor group, first comes the adductor brevis, then comes the adductor longus, and then comes the adductor magnus. The adductor magnus is the deepest muscle in the adductor group. So the function of this adductor magnus is adduction, external rotation, and extension. Next slide, please. Now this thin muscle, gracilis, it arises from the pubic crest and it gets inserted into the medial condyle of the tibia. Its action is adduction of the hip and internal rotation, and it is also weak flexor. Next slide, please. Sartorius, which is the it's a longest muscle, sartorius. We can put the cursor over there. Yes, it's a longest muscle and it arises from the anterior superior iliac spine and it gets inserted into the anterior medial condyle of the tibia. Its action is flexion of the hip and external rotation of the hip and abduction. It is also called as Taylor's muscle. When that position is there, that is the position they use it for pedaling the machine. So it is also called as Taylor's muscle. Next. Next, please. Here comes the rectus femoris. Rectus femoris, it has got, it originates from the anterior inferior iliac spine. Please show the anterior inferior iliac spine. Yes. This is the anterior inferior iliac spine. From there, it originates and gets inserted into the patella as well as the ligamentum patellae. It gets inserted into the patella and also to the ligamentum patellae. And it helps in the flexion of the hip and extension of the knee joint. It is a two-joint muscle. It works as the flexor of the hip as well as the extensor of the knee. Next. Now comes the hip rotators. Hip rotators are, please put the cursor, piriformis and superior gemali. Next, below that is the superior gemali. Below the piriformis. Next to the piriformis is superior gemali, and next to the superior gemali is the obturator internus. Yes, obturator internus, which is coming from the obturator foramen to the greater tuberosity, and this next comes the inferior gemali, and this small muscle below one, the lowest one, is the quadratus femoris, and this side is the obturator externus. Okay, next slide, please. Yes. It helps in the lateral rotation of the hip. All this muscle helps in the lateral rotation of the hip joint. Next slide, please. Yes, you can see the order. It is placed piriformis, superior gemellus, and obturator internus, and then inferior gemellus, and then quadratus femoris. Next slide, please. Yes, you can see the sciatic nerve that is coming below the piriformis muscle. Yes, next slide, please. Yes, this 6 hip rotator muscles, their action is external rotation. Those 6 rotator muscles are piriformis, superior gemali, and obturator internus, inferior gemali, quadratus femoris, and obturator internus. All these are the strong external rotators of the hip. Next, please. Next.
It's the last slide.
Oh,
31.
okay. Okay. Okay then. Thank you. Yes.
Question?
Yes.
Anyone got question?
Yes. Anyone? Hello. Yes.
Si Wendy, yan ako nag-refer ng patient.
Yes. Any questions?
Doctor, please tell the order of recovery in case of stroke patients.
What, sir?
Muscles order of recovery.
Yes.
Affected by the stroke patients.
Yes. Initially, we should work on the lower limb muscles. Gluteus maximus should be the first muscle that we have to treat. Even though we treat gluteus maximus, first day it will show some power, and after that day, the very next day, the gluteus maximus might show it is reduced, but internally other muscles would have got the strength. We have to check other muscles, because in then we have to work for the iliopsoas, and then we should work for the quadriceps, and then we should go for the hamstrings, and then the leg muscles, tibialis anterior and tibialis posterior, and then we should work for simultaneously also once we work for these leg muscles, we have to work for the abdominal muscles also. Without working for the abdominal muscles, I don't think so we will get the power that is gained by these lower limb muscles will not be retained. So we have to work for the abdominal muscles, and we should work for the extensors, back extensors, and then we should go for the shoulder joint or shoulder muscles. Because I was treating some patients, one young girl, she had this stroke, and I was treating her very next day. When on the day one, I just treated her. On that evening itself, she started walking with the support of her mother. Her mother holded her, and she was walking. And within 6 days, she started walking with the stick. And then she was crying, "Oh, I am able to walk now. Why don't you try for my shoulder muscles?" I told her, "You can. We have to improve more." "No, no, I am walking. Please improve my hand," she was saying. I just tried for the shoulder. Okay, let us try once. I was working for deltoid, trapezius. Nothing worked out. That day, even the lower limb muscles also was not improved. What was gained for till 6 days, it was there. But the 7th day session, nothing worked out. It means that we have to work for the lower limb very well, and then the abdominal muscles, and then the extensors of the back, and then we should proceed to the shoulder. This should be the order. Even in the shoulder, first we have to work for the deltoid muscle, and then the trapezius, scapular muscles. Once the scapula and shoulder are very well stabilized and they work in coherence, then only we can get the improvement in the elbow as well as the wrist extensors. Otherwise, I don't think so the person will get improved if we start working on the extensor muscles initially. Yes, sir.
Will you please repeat, madam? Please. Will
Yes.
you please repeat, madam?
Yes, yes,
Order,
yes.
we could not write down, teacher.
Dr. Vani, we could not write down because it was too fast for us.
Sure.
Please
Sure.
repeat, only we'll
Okay.
just check
Yeah.
whether
Yes.
we have written it right.
Okay.
Thank you very much.
First is the gluteus maximus, and then iliopsoas, quadriceps, abductors of the hip. Is it okay? I'm still saying.
Yeah, it's
okay now.
Okay. Abductors of the hip and the adductors also. And then we have to work on the pelvic muscles like quadratus lumborum, the most important muscle, which works very well, which compensate for all the activities of other muscles. So that should be treated. Quadratus lumborum, and then abdominal muscles.
What about quadriceps and the hamstring?
Yes, quadriceps I told. Quadriceps and then hamstring. Quadriceps, abductors, adductors, quadriceps, hamstrings, and simultaneously. So one day when it might be the order, but when you see the patient, for every patient, it just varies. It just varies. One day when we work on the because this abductors will be this quadratus lumborum will be compensating the movement. It will hike the pelvis. So the person will have this circumdactory gait also. So we have to work on the quadratus lumborum. When we are treating, first you start with the gluteus maximus, and then you go for the iliopsoas, because when we take muscle, you take the opposite muscle also to make it strengthen. You understand? First you are treating the gluteus and go with the iliopsoas. And then because once we work for this bigger muscles only, the person can stand. Even once one day I was going to treat the patient was not able to get up from the bed. She was asking the support from the people. So I saw, though I have treated gluteus, I saw that okay, she needs the support from the uh, abdominals. So I have treated her uh, transverse abdominis and yes. Erector spinae, yes, erector spinae also. Because when it is an order, we say it is an order, but sometimes this order also can change here and there. Here and there. It means you should start with the gluteus and iliopsoas, and then you should work for the quadratus and hamstring in the middle, because you have given the power to the quadriceps. One day you are giving power to the quadriceps. So that day when you have started treating, the patient was having power 1. But after your treatment, the patient has got power 2, 3. But very next day, when you see the patient will get the quadriceps power would go to 2. It doesn't mean the power what you have given has gone to somewhere else. No, it is wasted. It's not wasted. It has gone to the other internal muscles. Now you understood?
Yes, ma'am. Proceed, please.
Yes. So, yes, once we are treating this, again we have to work for the abdominals. In the middle also we have to take abdominals and the erector spinae. Again, once again we go back to the gluteus and iliopsoas. We have to check every day. The power keeps on changing, and we have to check what are all the activity the person is finding it difficult to work. In that manner, we have to work. You understood?
Yes, ma'am.
Yes.
Yes. And then this Even after treating the hamstring also, the gluteus power will not be 4 or 5. It would have gone to again 3 or 2 plus. Again, we have to treat gluteus one day. You got the point. So we are treating it in an order. One day the abduction will not come because the muscle keeps on changing the power. It's a dynamic thing. It keeps on changing its power. Even today I was treating her for the shoulder, and all of a sudden her knee she got a shivering over the knee. So it means that the power at one place is getting transferred and it is maintained. It is maintained. It doesn't mean that the pen we are using, it's giving power and it is maintained. But at the same time, we need to make the patient to do the exercise. Otherwise, the power will not be there for them. This is the reason some people say, oh, after giving the pen, the patient has got improvement. And after some day, within 2 days, they've come back. Whatever the improvement that they have got, they should maintain it with the proper exercise of that particular muscle. Otherwise, it will not be maintained. You got the point?
Yes.
The exercise is a must.
Yes, of course. Exercise is the must.
Okay, thank you.
How about yoga, madam? How about yoga? How about yoga?
Sir, think about the person who is paralyzed, how the person can do the yoga.
No,
You can ask them.
basic yoga.
One thing I want to tell you, see, yoga never gives you muscle strengthening. There is no, apart from Mayurasana and some asanas, there is no yoga that will help you in muscle strengthening. If you want to improve your pectoralis, how yoga will help? It is a stretching and flexibility only. And they are doing just 3 months courses. They're not from any university, is not giving, and they're not going for any exam. And I have so many yoga experts who are suffering from backache and paralysis also.
We'll talk later, sir. We'll talk later.
I can talk it about it because I have also done yoga and I'm a physiotherapist, I'm a homeopath, I'm a craniosacral therapist, I'm an osteopath. So don't go.
Sir, we are attending a class, sir. We are attending a class, sir. Please
that's what I'm giving you the answer. No, how yoga will help? Because the problem is in the brain. Even I also took classes. Even I took classes in Zoom for you.
Okay, sir.
So it is not a 5 years course. Which university is giving yoga course?
Sir?
So don't take it with physical therapy.
Not time for fighting, please. We are in the
please.
finish. No more. Continue, Dr. Vani, please.
Yes. So we are treating the leg muscles. At the same time, one day or other, see, even when we treat the hamstring muscle, the hamstring knee flexion will come. It doesn't mean it won't come. When you keep the pen and when we treat the patient with the pen, immediately the patient gets the movement. They're all shocked. We are even, it's many times Rahul sir used to say, it's miraculous. But once we feel it only, we can see that miraculous thing. Until and unless we treat the patient, we will not be able to feel the miraculous effect of this pen. It's really miraculous only. And then hamstring muscles, even if it is flexing, the person should maintain the flexion activity of the knee. Otherwise, it will not be there. We should teach them the flexion activity, and if it is power 2, the person has got power 2, then we should teach them in gravity eliminated position. If it is 2 plus, we can ask them to do it with little support. We can ask the patient to do the knee flexion. Like that, we have to teach them several exercises. Along with the exercises and NABS, it's really miraculous. Anything else?
Can you hear me, ma'am? Yes, ma'am, we can hear you.
Please continue, madam. First, after leg muscles, thigh muscles, after abdominal muscles, then go for back.
Back, yes, sir.
Please continue.
Yes. Again, when we are treating this abdominal and back muscle, we have to check the hip muscles once again. It doesn't mean we have treated the abdominal and back, everything is fine. Again, we have to check which is lower. If sometimes whatever the adductors that we have treated also, it would have lost some power. So again, treat the adductors. If you are treating adductors, that day you have to treat the abductors also to make the muscle balanced. You understand? We have to treat the opposite group together. Then only we can make the muscle balanced. And then you have to work for the leg muscles. Leg muscles are tibialis anterior, tibialis posterior, gastrocnemius. All these muscles we have to work, and then we should go for the smaller muscles of the foot. Before treating the bigger muscles, we should never ever go to the smaller muscles. It will not give effect at all. We feel like, oh, it's not working, but it works. We should use it in a proper manner. Even the magic wand, we have to say the spell in a right manner. If we don't pronounce it properly, it's not going to work. Similarly, this magic wand of Sastri sir also, we have to use it properly on the muscle. The bigger muscle should be targeted first, and then we should go for the smaller muscles. And then after, once we see, okay, all the muscles are getting strength in the leg muscle. Even if you try, that patient is walking and the patient is able to stand well, even if you see, okay, they are doing well, if you go and try the upper limb muscle, surely you can see the shivering of the lower limb. The person can feel the weakness of the lower limb because the power is going to the upper limb from the lower limb. That's why, again, if you treat some shoulder muscles like one or two, again you have to treat the weaker movement. The patient complains of some movement, that one particular movement is in trouble for them. Again, you have to check which movement the patient is having trouble and which muscle is causing that trouble. That you have to check and treat it. Even if I say the order also, it will not be like, if you go blindly with the order, you will not be able to get the result. That's why, like, you have to check again and again. The treated muscle should be checked again whether it is maintained or not. If the power is not maintained, we have to treat it again. And then once these lower limb muscles and the abdominal, the core muscles are treated, we have to go to the shoulder, upper limb muscles. First, it should be the shoulder muscles, and then the scapular muscles, and then the elbow muscles, and then you have to come to the wrist muscles. And we have to encourage the patient to do the simple abdominal breathing exercises. Otherwise, they cannot feel the difference, because many people, even if I suggest you do the breathing exercise, they don't understand. Once they are seeing the improvement, once the patient is seeing the improvement, that she has got the improvement, he or she has got the improvement in the lower limb, when we try it on the upper limb, that time they will see, oh, this power, whatever we have gained, is going to somewhere, and we are shivering. We have to do the exercise. Exercises are must. Without exercise, it is very difficult to maintain the power. Okay, is it clear?
Yeah, that's clear. But I want to treat the ankle and also the. Now you told us about all the muscle from the anterior and posterior back muscle and front muscle, upper limb, lower limb,
Yes.
and wrist. That when we treat the ankle and foot,
Yes.
when
Because when you see the muscles of the knee and the hip, and these muscles are stronger, then only we should treat the ankle muscles. But we can ask them to do some movement, because while walking itself, they will utilize some of the ankle is getting the some kind of reinforcement over the ankle muscles. So that will be enough. But first, without giving the power to the bigger muscle, we cannot improve the smaller muscles. Even if we see that in one particular session it has come, and the very next session it will go.
oh, okay, yeah. Thank you, Vani.
Okay.
Okay, doctor. How many group of muscles maximum can be treated in one sitting?
So with needle, I would suggest 2 or 3 muscles, and without needle, you keep the pen over the NIBS position. You treat some 5-6 muscles also. I do that. Because with the needle, if the person is strong, if the person is positive, if the person can withstand, and I have seen the people with negative attitude, my God, we cannot treat them more muscles also. Their brain starts rejecting it. If the provided the person is positive, we can go without needle and with needle technique also.
Hello.
Yes.
Ma'am, you said there will be shivering of upper limb. So, is it happens during treatment or afterwards?
No, I said that if the lower limb has not got the power completely or it has not gained the strength, and if we treat the upper limb without giving the power to the lower limb, if we treat the upper limb, even for the shoulder flexion also, the knee starts shivering.
Okay. But it happens during treatment also, it may
Yes. It indicates the power is getting transferred.
In such situations, what to be done, ma'am?
Please treat the bigger muscles. Don't go with the patient words. They say many things. We have to be strong with our method.
Okay, ma'am. Okay. But it can be controlled. That shivering can be controlled at that time.
Yes.
Okay, ma'am.
Again, you treat the knee muscle and the shivering can be controlled.
Okay, ma'am. Okay, thank you, ma'am. Thank you.
Okay.
How to check the muscle, madam, manually? How to check the muscle?
Manual muscle testing is there for each and every muscle. The manual muscle testing is there. According to that, we have to check the power of the muscle.
Okay, madam. Thank you.
Ma'am, about the diaphragm, I just wanted to ask.
Yes, ma'am.
When would we give the stimulation to the diaphragm? Is there any protocol for that? Because you have told the abdominal muscles and the core muscles.
Yes. In abdomen.
We do it along with gluteus maximus and iliopsoas or after that?
No, first you treat all the core muscles and then you go for the diaphragm also. Abdominal muscles, when you are treating the abdominal muscles, you see the abdominal movement are very good, the abdominal strength is good. Then you go for the diaphragm also. That time itself you treat the diaphragm. Because without proper breathing, how the person will get the oxygen supply? How the brain will recover? So that we have to concentrate.
Very much.
Yes. Anything else? Shall we close the class?
One more questions, madam.
Yes.
How many exercise should we be given after the stimulation?
Which muscle you are stimulating, you see, and according to that muscle you have to give the exercise, and based on the power of that particular muscle, what it has gained through the treatment, we have to check and then we have to give the exercise according to that power of that muscle. You understood?
Yes, but how long should we be given? Like in one session or in throughout the whole week, they will have to repeat that exercise until next.
Until and unless the main muscles get the power, we have to ask them to do the exercises repeatedly. Even though you treat for 1 hour, 1.5 hour a day, and then you ask them to do the exercises. Even with the exercises, you treat them with the exercises. At home also, you encourage them to do the exercises because they themselves will realize once we treat the patient with NIBS method, they themselves will realize exercise is very important because without exercise, they won't be able to maintain the power. In such case, surely they will they will do the exercise.
I see. Thank you, madam.
Okay.
Madam, one more question.
Yes, sir.
In case of hemiplegia patients, the good side also, I can see some patients are weak.
Yes.
So how to treat these type of patients first?
Yes, you ask them to do the exercise for good side at home because they will not be able to do at the affected side. You ask them to do the exercise for good side at home. That's what I'm saying. If they don't do, they will experience the pain in the good side. Because that power is coming to here, so surely they will experience the pain. And that we have to educate them, that we have to teach them exercises are very important. Not only the medication, not only my treatment. If you don't work, this improvement will not sustain. We have to educate them. That's very important. But normal side also they should do the exercises.
So what I am saying is, first we got to concentrate on the good side. We got to get or recover full strength in the good side. Then only we can.
It's not like that full strength you can't give, sir, because you're working on the other side. The power from there also it will come. So you have to keep on working together. Affected and unaffected, both to be worked together.
Welcome.
Okay.
Can I ask a question?
Vani?
Yes, sir. Yes, sir.
Yeah, I have a friend. When he stand and walk, no pain, but when he sit, it's very painful. To the extent he cannot stand up. What muscle is responsible?
Please repeat it, sir.
I have a friend.
Okay.
When he stand and walk, no pain, but when he sit down, very painful. To the extent he cannot stand up. So, what's the problem?
Work on the core muscles, sir.
Core muscle.
Core muscles, yes. Yes. Even if you don't have the rights to use the needle, you can go with the pen. Simply use the pen on the brain stimulation, that scalp method. That's more than enough.
Okay, thank you.
Okay. Okay. Is it?
May I ask?
Yes. Yes, ma'am.
Can we treat the major core muscles after which proceed to the lower limbs?
Yes.
At one session.
But we have to see, the person's attitude is very important. If the person is negative, even if you treat gluteus also, even if you give power 4 also, very next day it will become 2. So we have to counsel them. We have to ask them to change their diet, and many things has to be done. Only it's like they will get the power immediately. Sustainability of the power is there is in their hands, that we have to educate them.
Okay, thank you.
Okay. Yes, any questions? Any questions? Shall we close the class?
Yes, thank you.
Thank you so much. Thank you so much, Dr. Vani.
Thank you.
Thank you.
Thank you so much.
Vani. Thank you so much. Thank you.
Thank you.
So much.
Thank you,
Dr. Vani.
Vani.